Good morning, good afternoon, and good evening. Welcome to the virtual Fast Track Cities Conference and this presentation on HIV and coronavirus co-infection. Today we will focus on what we have learned from the published co-infection case series on HIV and the coronavirus. My name is Dr. Chris Duncombe. I'm the Chief Medical Officer at the International Association of the Providers of AIDS Care. So the objective of the presentation is to answer three questions. Are people living with HIV more susceptible to COVID-19? Is COVID-19 clinical disease course any different in people living with HIV compared to the general population? And finally, do people living with HIV have a higher risk for mortality from COVID-19 compared to the general population? We will try to answer these questions through the lens of the published co-infection case studies, including the recently published systematic review of 25 case studies. We will also look at three large public health databases. These are the Western Cape Provincial Health Data Centre in South Africa, NHS in England, and the Veterans Aging Cohort study in the US. Of the 25 studies, I've selected a few to help answer our three questions. There are two case series from Barcelona. You can see the small numbers here. In the first one, there were 5 people with HIV who had COVID-19. And in the second one, there were 53 co-infected people. There is a small case series from Istanbul, one from Milan, a multi-center study from Germany, and just recently published a case series from Atlanta, Detroit, and Rhode Island. I will show data from 2 case series in New York, one from the Basque Country in Spain, and one from Padua in northern Italy. And here are the three the three large databases: the Western Cape Department of Health in South Africa, 12,500 people with COVID-19, 435 deaths. The US VAX cohort, 253 HIV positive and COVID positive veterans, and NHS England with 14,000 COVID-19 deaths, 25 of which were among people with HIV. To finish the talk, I will present data from the just published systematic review of 25 case series. So the first question, are people living with HIV more susceptible to getting COVID-19? Let's start with the first case series that was published back in March of this year. This came from Barcelona in Spain. The series reported on 543 consecutive patients with COVID-19 admitted to a hospital in Barcelona. 62 or 12% of these people were admitted to intensive care unit, and 5 or 0.92% were HIV positive. Of the 5 people, 3 were male and 2 were transgender. You can see the age of the 5 patients, generally a young group of people. 3 of them had no comorbidities, 1 had a thyroid condition, and 1 of the patients had asthma. You can see the CD4 counts here. Patients 1 through 4 had very good CD4 count. Patient 5, who was not on ART, had a CD4 count of 13. Here are the viral loads. 4 patients had undetectable viral load. The 1 person who was not on ART had a high viral load. Their antiretroviral treatment included tenofovir, boosted protease inhibitor, and integrase inhibitor, and non-nucleoside reverse transcriptase inhibitor. Patient 5 was not on ART at all. People with HIV accounted for 1% of the 543 admissions with COVID-19. All were younger than the age of 50. The COVID-19 clinical picture resembled the general population, and all patients recovered. The second case series from Barcelona was published in August. It was a prospective observational cohort study which enrolled 53 people living with HIV out of a total of 5,683 diagnosed with COVID-19. This is 0.9%. Of the 53, the median age was 44 years. CD4 count, median CD4 count was 618. And all but 2 individuals were virologically suppressed. 2 patients, or 4%, died. The standardized incident rate ratio for COVID-19 amongst people living with HIV was 38%, compared to 33% for the general population. And as I mentioned before, people living with HIV represented 0.9% of the COVID-19 cases. In the first of the New York City case series, the characteristics of 5,700 hospitalized patients admitted to 12 New York hospitals were described. "43 of the 5,700, or 0.8%, were people living with HIV. Key messages from this case series were that with a median age of 63 years in this cohort, 21% of people died. The background prevalence of HIV in New York City is around 1.3%. In this case series, 0.8% of the 5,700 admissions were HIV positive. The authors concluded that HIV in itself does not appear to be a risk factor for acquiring the coronavirus. In the second New York case series, 31 of 2,159 hospitalized patients with COVID-19 were people living with HIV. This represented 1.4%. Based on an estimated HIV prevalence of 1.5% in this hospital's catchment area, the data do not suggest increased rates of coronavirus acquisition or hospitalization in the HIV positive population. 8 or 25.8 patients died. 4 were aged 50 to 65, and 4 subjects were aged greater than 65. Finally, 2 small case series just published, one from Spain, one from northern Italy. In Spain, among a cohort of 902 people living with HIV, 8 had confirmed COVID-19 infection for a cumulative incidence co-infection of 0.89%. In Italy, the HIV clinic at the University Hospital of Padua takes care of 1,745 people living with HIV, and overall 0.15% of the cohort were diagnosed with coronavirus infection. So summarizing these data on rates of infection amongst people living with HIV, in the 2 Barcelona case series, the rates were 0.9% and 1%. In New York, the rates were 0.8% and 1.4%. In Spain, it was 0.89%. In Padua, it was 0.1%. So the takeaway message here is that there are consistently low rates of COVID-19 infection amongst people living with HIV in these case series with small numbers. So let's turn to our second question. Is the course of COVID-19 disease different in people living with HIV compared to the general population? In this case series from Milan, researchers conducted a retrospective chart review of a hospital database of nearly 6,000 people living with HIV between February and April of 2020. 47 people were diagnosed with HIV, COVID-19 co-infection. The case series describes their demographic data and clinical outcomes. Mean age was of the 47 patient, mean age was 51, CD4 count was 636. 94% of these people had suppressed viral load, but 64% had at least one comorbidity. And interestingly, 13% of this case series were healthcare providers. %28 of the cohort were hospitalized, and the time from onset to recovery was about 14 days. (45) or 96% fully recovered. 2 patients died. One was a 47-year-old overweight man without other comorbidities. Another had cardiovascular disease and a recent diagnosis of lung cancer. Key messages from this case series are that 2 out of the 47 people, or 4%, died, and the crude mortality rate amongst HIV negative patients with COVID-19 at this hospital was 17%. The risk of severe COVID-19 disease amongst people living with HIV was comparable to the general population. In fact, the risk of death or admission to ICU in this case series was lower than that observed in HIV negative population. In this multi-center case series from Germany, researchers retrospectively analyzed anonymized data from 12 participating centers. 33 people living with HIV had confirmed COVID-19 disease. The mean age was 48, and 30 out of the 33 were men. All were on antiretroviral therapy at the time of COVID-19 diagnosis. The median CD4 count at diagnosis was 670. 1 person had a CD4 count of 69. 60% had comorbidities including hypertension, COPD, diabetes, cardiovascular disease, renal insufficiency, and hepatitis B infection. 30 out of the 32 had suppressed viral load. (29) of the 32 recovered, with 76% being classified as having mild disease and 24% categorized as having severe or critical disease. 3 patients died. Patient 1 was aged 82 and had a detectable viral load. Patient 2 had a CD4 count of 69, and patient 3 had multiple comorbidities. The authors concluded that data from this small case series did not support excessive morbidity or mortality amongst COVID-19 people living with HIV with viral load suppression and on ART. This is another small case series of 4 people living with HIV from Istanbul. 3 people were on ART and were virally suppressed with good CD4 counts. 1 person was not on ART and had a high viral load. Three of the 4 people recovered. 2 of them were on ART with viral load suppression, and 1 had advanced disease, not on ART, also recovered. Chest X-ray findings were similar, irrespective of CD4 count. The 44-year-old patient who died had multiple comorbidities, including hypertension, diabetes, COPD, and obesity. This was even though his viral load was suppressed and he had a normal CD4 count. These are the three just published case series from Atlanta, Detroit, and Rhode Island. In Atlanta, 20 out of 500 people, or 3% of hospitalized admissions with COVID-19, were people living with HIV. 3 of those people died. All had a CD4 count greater than 200 and were virally suppressed, but each had 5 total comorbidities. In Detroit, 14 people living with HIV were admitted, 3 of whom were virally suppressed, and 3 died. The authors concluded that although the clinical spectrum of COVID-19 amongst people living with HIV cannot be fully ascertained from this report, it adds to the data that suggests that HIV positive patients with coronavirus infection are not at greater risk of severe disease or death compared to HIV negative patients. Finally, in Rhode Island, 27 people living with HIV were admitted to hospital, all with undetectable viral loads and CD4 counts between 87 and 1400. 1 person died. The authors concluded that the clinical presentation and outcomes of COVID-19 appear to be consistent with those without HIV. So finally, our final question: do people living with HIV have a higher risk of mortality from COVID-19 compared to the general population? Mortality rates from COVID-19 vary. Depending on age, rates can vary from 0.2% for people in their 20s up to 14.8% for people 80 and above. That's the graph on the left-hand side of the page. On the right side, rates also vary according to comorbidities, with a mortality rate of 0.9% in people with no health conditions, up to 10.5% for people with cardiovascular disease. Observed case fatality ratios also vary by country for reasons which are not clear. You can see here that in the US, it is 3%, and in Italy, it is 14%. In this retrospective analysis of 375 patients admitted to a community hospital in New York, 57% of people survived and 43% died during hospitalization. Hypertension was the most common comorbidity, followed by diabetes, cardiovascular disease, and chronic kidney disease. 9% of people who died had HIV. On multiple regression analysis, the key factors associated with mortality were age, admission D-dimer, admission C-reactive protein, and admission lymphopenia. D-dimer and C-reactive protein are markers of inflammation and hyperinflammation, and elevated levels are associated with the so-called COVID-19 cytokine storm, which predicts mortality. HIV was not associated with increased mortality. So now let's turn to the 3 big databases. Open Safely is a new data platform in England which addresses COVID-related questions in real time as that country tries to reopen. It includes 40% of the English population, which is 17.3 million adults, 0.16 or 27,000 of whom had HIV. From this database, people living with HIV were threefold more likely to die from COVID-19 compared to those without HIV, adjusted for age and sex. And the hazard ratio for death was 2.90. The second of the large public health databases comes from the Western Cape Department of Health in South Africa. They specifically looked at the risk of death among people with HIV. The Western Cape has nearly 7 million inhabitants, 520,000 of whom are people living with HIV, and 90% of people are dependent on public sector health services. The Western Cape Provincial Health Data Centre consolidates administrative, clinical, laboratory and pharmacy data through electronic records, which are used in all public health facilities with linkages through a unique identifier. Overall, there were 13,000 cases of COVID-19 recorded with 435 deaths. People living with HIV had twice the risk of COVID-related death compared to those without HIV, irrespective of viral load suppression or ART use. The hazard ratio was 1.78 for death. The authors commented that the risk was modest compared to other risk factors such as age and diabetes. The hazard ratios are seen here on the graph on the right. You can see the hazard ratio at the very bottom for being HIV positive compared to the increased hazard ratio higher up for people with diabetes and higher up again for people of older age. The authors also commented on the possibility of unmeasured confounders and that the risk of death may be overestimated. While the database collects information on diabetes, hypertension, chronic kidney disease, COPD, asthma, HIV and TB, it does not collect data on cardiovascular disease, obesity or socioeconomic status, all of which have been associated with an increased risk of death from COVID-19. The Veterans Aging Cohort Study is a prospective observational cohort of HIV positive veterans with a matched age, race and site control group of HIV negative veterans in care in the United States. You can see the makeup of the cohort: 253 veterans with HIV and COVID, 2,346 with HIV and no COVID, 504 HIV negative veterans who had COVID, and 4,473 who had neither HIV or COVID. Among veterans with COVID-19, those with HIV did not differ from the HIV negative group in terms of hospital admission, intensive care admission, intubation, or death. The Montefiore Medical Center is the teaching hospital of the Albert Einstein College of Medicine in the Bronx in New York City. Montefiore cares for more than 4,000 people living with HIV in 4 acute care hospitals and 21 primary health centers. The population in this current study included 100 people living with HIV and 4,513 without HIV, all of whom had COVID-19. Most outcomes did not differ between HIV positive and negative patients, including length of stay, which was 5 days in both groups, and the likelihood of death while hospitalized, which was 22% and 24% respectively. So just summarizing in the graph on the right, the data that we know about mortality amongst people living with HIV. The database from the Western Cape and from NHS England said that there was an increased rate of death. The Montefiore, VAX, and the systematic review, which I'll show in a moment, said no. So the answer to the question is you don't really know from these data consistently whether people are more likely to die or not, and we need to continue to collect more data on this. So let's finish the talk now by reviewing the systematic review of COVID-19 amongst people living with HIV, published in July of this year. The systematic review included 25 studies and 252 people living with HIV who had COVID-19. The geographic distribution of the studies is shown here, with 8 studies in the US, 7 in China, 1 in Uganda, 1 in Turkey, 1 in Greece, 3 in Italy, 1 in Germany, 1 in the UK, and 2 in Spain. I presented earlier in this talk data from 12 of these studies. Some key demographics of the 252 patients: 80.9% were male. The mean age was 52.7 years. 98% were on ART. 99% were virally suppressed, but 13% had a CD4 count of less than 200. Summarizing here comorbidities and outcomes, common comorbidities included hypertension, obesity, hyperlipidemia, COPD, and diabetes. And you can see the percentages here ranging from 39% for hypertension down to 17% for diabetes. 2/3 of the patients had mild or moderate COVID symptoms. 36 out of 253, or 14.3%, were reported as having died. Among the patients who died, the majority, or 90%, were older than the age of 50, and 64% had multiple comorbidities. The authors of the systematic review concluded that with available data, people living with HIV are largely affected by COVID-19, similarly to HIV uninfected people. That multi-morbidity and older age were important factors for disease severity and mortality in patients living with HIV. Key clinical symptoms of COVID-19 for people living with HIV were cough and fever, and these were comparable to people who do not have HIV. And finally, the majority of people with HIV had mild disease. Of the 252, mortality among people living with HIV with COVID-19 was high, with a 14.3% pooled estimate. The authors commented that the result may be confounded by other factors, that people living with HIV may be at increased risk for mortality because of age or other medical factors. Among those who died, multimorbidity and older age were common. The conclusion from the systematic review was that current clinical data suggests that the main disease severity and mortality risk factors are linked to older age and morbidity, and not particularly to HIV. However, this is a rapidly evolving field, and I think the bottom line is that we need to watch this space and see what develops as we get more data over the coming months. If you have any questions or comments, or you would like a copy of the presentation, please feel free to send me an email. Thank you again for taking the time to listen to the presentation, and I hope you enjoy the rest of the Fast Track Cities virtual conference.